Good afternoon. I'd like to talk about two competing models in United States health. One, the patient-centered model, and the second, the community-centered model, health in place. Currently, there's tremendous struggle going on with the insurance companies, with Medicare, with Medicaid, in trying to reduce costs of health. And the predominant notion with people in insurance and in health is that by making health more patient-centered, they would be able to harness the patient from the time the patient comes into the health system to the time that the patient gets back home. And that's kind of a funnel where each patient is funneled through the practice or the health system, and the system can cast a net around it and theoretically manage the cost of health. The reason why there is such a debate going on with the cost of health, because the United States uses a system called fee for volume. And fee for volume is a system that was developed by the people with MBAs to get the most you possibly could out of a human being's poor health on the road to good health. So each procedure that's done by a doctor is recorded on a sheet, and it has a code, and a group of people decide how much each code pays and how much reimbursement the patient will give and the insurances will give. That system has become overloaded, whereas other countries have produced a system for value and not volume. Think about it like this. If you brought your car in and you had a couple bad spark plugs, and they put in two new spark plugs, and the car still sputtered along after you paid your bill, you would bring the car back and you'd expect that they would fix it for nothing. And they do, 95% of the time. And that's value. You get your value out of your service. When we go in with a problem, we can go into the hospital 3 and 4 and 5 times, sometimes with the same thing or a related thing, and the hospital still gets reimbursed whether we're fixed or not. And that's fee for value. The big drivers of medical costs in the United States say that we've got to move to value. We've got to catch up to these other countries because we have high costs and we don't do as well as 28 other countries in health outcomes. Now, one of the measures that Medicaid and Medicare, two big drivers, almost $1 trillion driver in health, government health, are working towards is developing a system that moves towards value by connecting people in the health system, in their jar, to community supports. But the community supports in the United States are loose, they're tangential, and they're not connected the way the medical system has connected all of its components so that they know with high tech what everybody's doing within their job. But in order to do community supports, they're going to have to connect those community supports to their high tech. But coming out into the community also means that they have to learn high touch. And that's not generally taught in medical schools or in MBA schools. And yet we have a voluntary sector that is based on both high tech within its sector, but mostly high touch. It's person to person and intervention, and a lot of it is voluntary. And in order to have that original support system that we had in the United States since before nationhood, that we're going to have to introduce slowly but surely high tech and high touch so that we can connect the both, so that we can move from patient-centered health to community-centered health. It's not going to be easy, but it will be necessary. And here are the reasons why. Okay. In the United States, there are 350,000 religious congregations. Now, most people call them houses of worship. But besides being houses of worship, since nationhood, when the Continental Army contracted with the Philadelphia Quakers to move their poorhouses to become hospitals for Continental Army soldiers, we've had a long connection between health and the service part of the faith community since before nationhood. And that's where we're headed. We're headed back to the future, because to get to indigenous community supports and connect them, we're going to have to be connected to the faith community. And here's the reason why. Okay, we have 41,700 zip codes in the United States. Do the math. There's 8 congregations per zip, and approximately 4 of those 8 are already partnering with nonprofit and governmental agencies, and quite often with each other, to take care of the needs beneath the radar in the community on social, health, artistic, educational, you name it. But we would be building off of strengths. If the United States is ever going to have a system of community supports, it will have to build where the supports are. As noted, 175 already partner with nonprofit organizations and each other, and so that's where the strength is. It's a weakness for the health system because it's inside of its jar, and it really doesn't know how to behave out in the voluntary sector because there are different kinds of norms and values from what's inside the health system. By and large, as marvelous as our doctors are and our health system is, when we're compared to other cultures who are taking health in a cultural context, that they need a healthy culture to succeed economically, we don't do very well compared to other countries. Who is Willie Sutton? Willie Sutton is America's most infamous bank robber. And he was asked one question that is telling for not just Willie Sutton, but for how we would conceptualize community supports. He said, "Why do you rob banks? That is where the money is." And Willie Sutton's notion can be transferred. If we are going to build community supports, why would we start in a zip code? Because the supports are in the zip codes, and they're called congregations, and they already do service. They've been doing health service. That's why we have Wake Baptist Hospital. We have Beth Israel in New York. We have St. Jude's. We have 600 Catholic hospitals in the United States. We already have the indigenous support from these congregations that were there a long time ago. Now we're going to have to go back and build off of that strength if we want to reintroduce support. Our next graphic takes a different slant. It examines the number of suicides in a zip code and the number of, and where the churches are located. Now think about it like this. People are murdering themselves in very close proximity to churches. Now, churches could be education centers where we reduce the stigma of mental illness. People are suffering, but they don't know what to do. And right next to them is a place that says it's not morally right to stigmatize people, nor to kill yourself. Because when you kill yourself, you kill your family and your network. And in zip code 27406, we have 5 interventions for mental health services. We have the emergency room. We have the jails. We have 2 million people in jails today who are mentally ill. They should be served. We have the funeral home. We have a trip back to the church. And we have the cemetery. Something's not right if those are our only 5 intervention spots for dealing with behavioral health issues. We can do better than that. When you think outside the jar and you want to have a relationship in the congregations, we have developed an intricate set of metrics. Keep going. Metric number one, that regardless of what your station is, whether you're a health leader or police officer or EMS, when you come into the congregation, there has to be a handshake. Next metric. If there's any chance of a collaboration to take place over the long term with these indigenous community supports, you're going to have to be able to hug each other. Handshake and a hug. Next metric. If you can get past a handshake and a hug, then you're going to have to break bread together. And breaking bread together is a highly symbolic notion that we're beginning to build trust. Go ahead. The fourth metric is that you're going to have to worship together, meaning you're going to have to go to the houses of worship and participate in worship services. If you're a non-believer, fake it until you make it, because the bigger good is more important than your own personal beliefs. If you do those four things, then you have the possibility of sitting down and doing a collaboration, because you have begun to build trust. You'll have to do those four things over and over again to build long-term, lasting relationships. But those are the metrics that you're going to have if you're going to build common unity.